Ladies and gentlemen, thank you for joining our e-seminar today. My name is Teresa Boone, and I'm the Director of Global Education at Natus Medical, and I'm delighted to moderate today's presentation, Concussion Management, Stability Evaluation Test, and Dynamic Vision Testing with Gross Motor Evaluation. Without further delay, I'm going to go ahead and get started and introduce our speaker, Dr. James Masterson. Dr. Masterson has quite an impressive biography. Hailing from Western Pennsylvania, he graduated from the University of Pittsburgh with a degree in chemistry and completed medical school at Philadelphia College of Osteopathic Medicine. He completed his residency at Doctors Hospital in Columbus, Ohio, and is board certified in family practice with a certificate of added qualification in geriatrics and sports medicine. Dr. Masterson has provided medical care in Greensburg and the surrounding areas since 1990. He has been a team physician for a Hempfield Area School District for the past 13 years and provided event medical coverage for members of the U.S. Olympic Gymnastics team during the Tour of Champions following the 2004 and 2012 Olympics. He's the founder and present director of the Progressive Concussion Program at Excella Health. Without further delay, I'd like to get our program started. Dr. Masterson, the presentation is yours.
Thank you very much. I appreciate the opportunity to talk to you all this morning. I always enjoy a chance to get to talk about concussion a little bit. So this is a different format for me, but I think it's great. So if you've seen one concussion, you've seen one concussion. And that really is true with this injury, and it's kind of one of the reasons why I really enjoy working with concussed athletes, because your brain controls everything you do, and every concussion is different. And not only are the symptoms different, not only do sometimes we see a kid who has primarily balance-related symptoms, and sometimes a kid who has cognitive symptoms or emotional symptoms, but the situation also varies. You know, we'll see kids that are lacrosse players who have dreams of playing lacrosse in college and want to get back, as quickly as they can to that sport. And sometimes we'll see kids that are on their second or third concussion, and they're, playing football presently, but they're a discus or a shot putter, and with potential to do that in college. And all that is going to influence the decision making when it's time to make that return to play decision. So what we want to do today, we want to talk a little bit about the result if concussions are not detected and managed appropriately. Go over what we do at our center, concussion testing, and what we believe should be done. We'll, hopefully have some time. I'm sure we'll have some time for questions and to discuss things in more detail afterwards. So concussion's big news. It's everywhere. Time Magazine, Sports Illustrated, multiple books that have been put out. So it's talked about a lot. And one of the reasons that it's really talked about a lot is the finding of chronic traumatic encephalopathy, or CTE, in the brains of retired athletes, or some of our retired athletes. So, and listen, this is an area that there's some controversy around. This isn't a sure thing by any means, but it is something that has been in the news and has raised a lot of stir. It all started in 2002, really September of 2002, when Mike Webster died of a heart attack. And there's a neuropathologist, a new neuropathology graduate from the University of Pittsburgh by the name of Bennett Amalho. And Bennett Amalho was watching the news. He knew nothing about American football, but he watched the news stories about Mike Webster and saw where the claims were that maybe he really didn't know how to handle life after professional football, that his life had kind of taken a downward spiral, and to the point where he had several failed businesses, a failed marriage. He was living in the back of this, or in the inside of a Chevy S10. And Bennett Amalho had studied boxers and had seen this thing called dementia pugilistica in their brains. And he kind of thought that even though he didn't know much about American football, he knew that it was a violent sport and a collision sport, and he kind of wondered, could Mike Webster have something like that to account to his, for his behavior? Maybe it wasn't all just not knowing how to cope with life after football. So happened when Bennett Amalho went to work that day, Mike Webster's body was on his table, and it was there because somebody had put post-concussive syndrome on the autopsy report, so it became a coroner's case. And Dr. Marlowe, went about the autopsy expecting to find the changes that he had seen before in dementia pugilistica. But when he opened Mike Webster's skull, what he saw was a pristine, normal white brain. But he studied it further, and actually studied it for about 6 months. He did different stains, and finally he found this deposition of tau protein, TAU protein in Mike Webster's brain, and it was in a distribution that hadn't been seen before. And that's really the key to CTE. It's not that there's a buildup of tau protein in the brain. We all have some tau protein in our brain. Life is kind of a progressive tauopathy. We all get some tau protein in our brain. But it was the amount of tau protein and the distribution of tau protein, which was really unique in Mike Webster's case. And since then, there's been many other athletes. On the slide we showed Terry Long and Justin Strelsick and Andre Waters, and each one of these guys has their own story. Reggie Fleming, whose kid was a paranormal filmmaker, and he actually showed Reggie Fleming's life as it progressed and kind of the dementia changes that he went through. John Grimsley, who was an avid outdoorsman, accidentally shot himself with a hunting rifle as he was cleaning it, which, when you talk to his wife, she would say that this is something that was really uncharacteristic, and she would just, kind of say over the past few years how he would forget what he went to the grocery store for. Tom McHale, a Cornell graduate, one of the smartest guys in the NFL at his time, Robert Probert, of course, Mike Webster, Derek Bugard, Owen Thomas, the kid from the University of Pennsylvania, committed suicide. Dave Dewerson, a Notre Dame graduate who played in the NFL, played on the Super Bowl Chicago Bears team, and was on the NFL brain trauma committee, who shot himself in the chest, most people think, so that his brain could be studied afterwards. Chris Benoit, the professional wrestler, whose claim to fame was he wanted things to look very real, so he took the chairs to the head and didn't use the collapsible chairs, and unfortunately that didn't pay off for him. He actually strangled his son and his wife, and then hung himself. Michael Borg was big news at the time because he was the first non-professional player, and he was a wide receiver found to have CTE. Chris Henry, the troubled wide receiver who either jumped out or was pushed out of the back of a pickup truck, and Wally Hilgenberg, to name a few. There's a lot of examples of what is thought to be CTE being responsible for these players' kind of demise and eventual death. Now, one thing I always want to say, and especially if we're talking to a group of parents or a group of kids, sports isn't the problem. I love kids playing sports. We do sports medicine because we believe there's such a good benefit for sports for our young people. I don't think that this happened because of sports or even because of concussion. I believe it happened because of the way the concussion was managed and that repeat injury before the brain was really healed during that vulnerable period where that big cascade is going on and sodium's going into the cell, potassium's coming out of the cell, and calcium's going in, and there's an energy crisis. So all that change is going on. If you get re-injured during that period of time, that's when you really get into trouble with it. This is actually Dave Dewerson's brain, and there's a real characteristic distribution of tau in the deep cortical sulci, in the amygdala, in the temporal lobes, and the frontal lobes. There's nothing else that looks like that. If you listen to Anne McGee from Boston University, she'll tell you that distribution is very unique to this disorder. Junior Seau most recently. PET scan with FDDMP, something that the people at UCLA are working on. It's able to show tau protein in the brain. By no means does it diagnose CTE. CTE is a post-mortem diagnosis. I just got a call yesterday in our office, what to do. They had another office had somebody diagnosed with CTE. Well, again, it's a post-mortem diagnosis. You can't be diagnosed with CTE if you're alive. But Joe DeLima, Tony Dorsett, Leonard Marshall, three of the guys who have undergone the scan and are found to have tau protein in the classic distribution. Do they have CTE? Possibly, and maybe even probably, but we don't know that for sure. It's a term diagnosis. Chronic traumatic encephalomyelopathy, Lou Gehrig. Did Lou Gehrig's die of Lou Gehrig's disease, or did he actually have CTE with progression to those long motor neurons that control the muscles? That's a question that will never be answered because Lou Gehrig was cremated. People say, well, he was a baseball player. Well, he was unconscious 3 times during his baseball career, number one. And number two, he was a halfback at Columbia before he went in to play Major League Baseball. Maybe. We'll never know. But we do know that Patrick Grange's story is interesting for 2 reasons. Number one, he had ALS and then died at a pretty young age, and his brain was CTE. But the other thing is that he was a soccer player. And that's the biggest thing because he was the first soccer player diagnosed with CTE, which is big news. My mom always said if you can't say something good about something, don't say anything at all. So this is Jason Padgett, and Jason Padgett was kind of a thug. He was a wayward kid. He didn't do well in college and actually left college, went from bar to bar. And one night he was in a karaoke bar. And when he left the karaoke bar, he got beat up, and he got beat up pretty bad. They took his leather jacket. He went through a long recovery, and there was, a lot of complications. But the end result is he developed something called synesthesia, where senses kind of combine. A lot of people with synesthesia, when they see a number, they always see a color associated with it. He became a math savant. And he puts out some incredible artwork. So he'll look at an object, and he doesn't just see the object. He sees angles and mathematical equations. He looks at a circle, and he sees pi, and not the apple pie that I see, but he sees 3.14. And really, it's pretty interesting. And when you see the artwork that he has, he says that he wouldn't give that up for anything now, although he's had bouts with depression and other issues. But back to the, again, I wouldn't recommend beating up our wayward kids and seeing what happens. I think that's a unique case. But, back to kind of the real stuff that we're talking about. And Nathan Stiles, Austin Trent in the middle. This is Nathan Stiles. This is Jaquan Waller. Second impact syndrome, suicide. And second impact syndrome, by the way, so I didn't really talk about it yet. That's kind of the worst scenario if you get a kid who's concussed and in that vulnerable metabolic period of change and they get hit again. The body kind of loses its mechanism to kind of control the pressure in the brain and such. And you can get bleeding, you can just get diffuse swelling. There's not many cases, but it's either fatal or, about 50% of the time it's fatal, and the other 50% of the time it is life-changing in your severe neurologic deficit afterwards. So that's something that we never, ever want to see. Again, Owen Thomas, Eric Pelly, kid local for us, North Allegheny High School, died 10 days after his 4th concussion. This is his brain. You're starting to see that tau protein perivascular. They started to see it in the classic pattern associated with CTE, not to the level that we saw with Dave Dewerson's brain, but you're starting to see it there, and you're starting to see it down kind of in the cortical, deep cortical sulci. There were some other slides that showed that a little bit better. This is what we don't have. So we don't have anything that cures and prevents future concussion, and since we don't, and since we know we don't want our young kids to develop neurologic disorders as they get older, and we certainly don't want them to have second impact syndrome, we better have a pretty good way of diagnosing and following their concussions. And by the way, before we go on to the rest of the talk, I got back from the American Academy of Neurology sports concussion talk, which, by the way, was the very first time that the American Academy of Neurology has ever had a conference dedicated to one medical condition. So that kind of gives some emphasis to how big concussion is right now. But they had a very good speaker, a very good pathologist, Dr. Castellani, and in his talk, he said we really don't know enough about it to say that, playing contact sports and having repeated concussions has a potential causative role in phosphorylated tau protein building up in the brain and causing suicide and impulse control and the things that we just talked about. Now, if you talk to Ann McKee from Boston University, who's done more of these autopsies than anybody, I think you'd get a different story. But there's certainly some controversy out there. So, I want to put that in kind of as a disclaimer there. I think just about everybody there agreed that concussions that reoccur without the appropriate time to heal increase the risk of dementia, depression, personality changes, movement disorders, and such later on in life. Dr. Bill Meehan, and actually this study was just a very similar study anyway. It's repeated at UCLA. I'm drawing a blank on the name of the scientist who did that. But 3 different groups of mice were all concussed 5 times. One group was concussed 5 times at daily intervals. The second group was concussed 5 times at weekly intervals. And the third group 5 times at monthly intervals. Then they repeated the testing in Morris Water Maze. Morris Water Maze is a big tub of water that has a little platform underneath the surface of the water, and you drop a little mouse in there, and he swims around until he finds that platform. And it takes about 5 seconds for a normal mouse and about 25 seconds, say, for a concussed mouse. Well, 1 month after their last concussion, the group of mice that were concussed on a daily interval still took 25 seconds to find that. And 1 year afterwards, they still took 25 seconds to find it. So they never recovered. The group that was concussed on a weekly interval 1 month after their last concussion took 25 seconds. When they were rechecked 1 year after their last concussion, they had recovered. They were back to 5 seconds. And the group that was concussed on a monthly basis 1 month after their last concussion was back to being able to find that little platform in 5 seconds. So it does look like the timing of the concussions matter, that if we can prevent these kids from getting a repeat injury before their brains are ready for it, that we're really doing some good. That's what we hope. That's what we do is all about. So I hope there's some real benefit there. And I think just about everybody at that meeting was in agreement with that point. So here's what we're faced with. Can you see the difference between the 2 athletes? There isn't any, and most of the time that's the case. Most of the time when we see an athlete, you can't tell when you just walk in a room that they're concussed or not. That's not always true. I mean, sometimes the lights are off and they have sunglasses on and they look miserable, but we've had a couple kids that have actually come in wheelchairs, but the vast majority of the time, they don't look any different than if they're not concussed. So we need to have good tools. I mean, I think that's the bottom line. We need to have good tools. We need to have a lot of experience in order to follow these kids and make sure that they're not the next, Austin Trenum or Jaquan Wall or Nathan Stouts. Here's one little paradox that I just kind of wanted to show. And this is football stats. So these are the number of people in our country currently playing in the NFL. This is our NCAA Division I, II, and III athletes. This is the number of high school athletes. And this is our middle school and below. And as the numbers go up, the resources go down. So, these 3 million kids really rely a lot more on coaches and parents. They don't typically have an athletic trainer at the game. Thank God there's things like, Heads Up and USA Football and things like that now that are helpful. But the resources go down as the numbers go up. So we need to really serve these kids in that group. This is just a picture of a nice building. It's not where I work. It's where I hope maybe someday we'll work in a place like this. We currently work in a medical office building with a suite with 5 exam rooms and a balance room and a Dynavision room, 3 additional impact rooms outside of the 5 exam rooms. So but we're looking, and hopefully over the next couple of years we're going to have a real state-of-the-art orthopedic and sports medicine office. What we do, about 75% of what we do is concussion management, and about 25% is sports medicine, non-op orthopedics. We've been doing it for about 10 years with a full dedicated concussion program. For the past 4 to 5 years, we have 8 contracted high schools, 1 community college, 1 university, but we see kids from probably 25 to 30 local high schools. We do mostly sports concussion. We do see some workman's comp and auto accident. We're seeing a little bit more of that this time of year, and we see more of the other during the school months. We utilize athletic trainers. Athletic trainers are the real key and the real core in a good sports medicine program. Physical therapists are vital to us, and particularly with the injury that we're treating. Of course, there's a lot of cervical issues, so very helpful. We're super fortunate. We have 4 awesome vestibular therapists who we work with. That comes into play right now, usually about 3 weeks. If we're still seeing vestibular symptoms on exam, we'll refer to a vestibular therapist. And again, we have good ones locally, although that's changing. And more and more, we're starting to feel like we need to move that up a little bit, and maybe we need to move that a little bit sooner. Vision therapy, we're very fortunate to have an awesome vision therapist. There's a lot of controversy with vision therapy. Does it really work or doesn't it really work? And I can tell you from our experience, I have no question that it works. They get our hardest kids. They get the kids whose convergence is off and whose smooth pursuits is way off, and they're just miserable. And maybe they're already back to normal on their neurocognitive testing and such, but they're really symptomatic, and they're awesome. Exertion therapy is starting to play more and more of a role as well. We do post-exertion neurocognitive testing. Dr. John Leddy out of the University at Buffalo, I think, was the guy who really originated exertion therapy, kind of measuring the VO2 max and finding out what percentage of that caused symptoms and organizing or developing an exercise program and kind of retesting periodically and bumping up that exercise. So exercise increases the secretion of brain-derived neurotrophic factor, which we want. And there's kind of a sweet spot. Initially, right after that injury, we got to rest the kids. And maybe for a few days. Nobody knows where that sweet spot is where, if you start exercise, you're going to increase the brain-derived neurotrophic factor. Right after the injury, if you start exercise, you might actually decrease it. But down the road, you're going to increase it. So, and again, that's probably sooner. It's probably a week down the road or so. School nurses, we have good communication with our school nurses. We have a brain steps program for school reentry. We don't have these medical specialties in our office, but we've talked to those people. So if somebody needs a neurologist, it's not going to take 6 months to get in, but the neurologist we've kind of made that arrangement with will get the kid in sooner. Personal trainers, that's a new thing for us. We actually have a local chiropractor who is developing they call it a concussion program. It's kind of just an off-season conditioning program where they work with neck strength, core strength, and aerobic conditioning, because a tired athlete is more likely to be concussed, and an athlete with a weak core or weak neck muscles is more likely to be concussed. So I think that's a positive. We do baseline neurocognitive testing. We happen to use impact. Is a impact test an adequate baseline? No. There should be some balance assessment there. A little bit too late for this year, but I really do hope that we do some balance testing as our baseline starting next year, and I would encourage that for everybody. For our younger kids, we do a comprehensive baseline test. We do 3 things. We do the SCAT-3 child for neurocognitive evaluation. We do a Dynavision test that we kind of developed for kind of looking at your gross motor reaction time. We'll talk a little bit more about that. And we do the CTSIB component of the neurocom, which is awesome. We get that nice readout. We, of course, do concussion management after the injury. And I think the biggest thing, what's the 2 biggest things in sports medicine? It's accessibility and communication. So we do have instant communication with the athletic trainers in the schools as the kid leaves, and then gets faxed out to the school nurse and the athletic trainer. And that's probably more important than anything else we talked about. The tools, again, the neurocognitive testing, vestibular and visual testing. Right now we do manually in the office. We just do the finger and eye, smooth pursuits, VOR, saccadic testing, finger to nose, smooth pursuits and gaze stability, and of course convergence testing. We are really fortunate to have a Dynavision and a neurocom VSR Sport that our foundation was nice enough to fund for our program, and they've been absolutely invaluable. So neurocognitive testing, I don't think it matters what type you use. We use impact. because we're in Western PA and because impact has almost become synonymous with concussion care. It's the one that the NFL and the NHL and Major League Baseball uses. I don't think it's necessarily better than Coxford or Headminders or CNS vital signs or the military test, the ANAM. I don't think it's worse either. I think it helps us, so I think it's a good thing to have as an adjunct. But and I am a credentialed impact consultant, and this is just a little bit more about the impact test, the immediate post-concussive assessment and cognitive testing developed by Dr. Lovell at UPMC. Individual differences in how the individual athlete's brain works. So are they more visual? Is their visual memory better? Is their verbal memory better? What's their brain speed like? And again, the utilization is big throughout sports. But it is not synonymous with a concussion center. So, and that's kind of what, do you have a concussion program? Oh, yeah, we impact all our kids. They're not equivalent things. The impact is one part of it. You most definitely need to have some form of balance assessment. You need to be doing a much more thorough evaluation than just doing an impact test. So balance testing. Balance testing, March of 2013 was a big year for concussion. That's when the report from the consensus group on concussion. We met in Zurich in November of 2012, but the report came out in March, and that's when the American Academy of Neurology statement came out as well. Now, these don't sound too strong, but when you think about it, you've read the reports from these groups before, they're actually pretty strong. And the consensus group said that, published studies using sophisticated force plate technology, which we're lucky enough to use with our Neurocom system, as well as those using less sophisticated clinical tests, the best tests which you use for years, have identified acute postural stability deficits lasting approximately 72 hours. We've seen them lasting a whole lot longer than that following sports-related concussion. So they mentioned that you probably should be doing some type of a balanced assessment in there as well, and I wholeheartedly agree with that. I've seen kids who fly through the neurocognitive portion that have a lot of trouble with balance. The AAN also mentioned balance in their report. They said that balance testing, such as the balance error scoring system, may be helpful tools in diagnosis and management of concussion, but again, should not be used alone, and none of these tools should be used alone. The BEST test, I'm talking to a group that's very familiar with the BEST test. We used it for years, and I think it's a good test. Standing on a hard surface, hands on your hips, feet together for 20 seconds, non-dominant leg for 20 seconds, non-dominant leg and back for 20 seconds, and then the same thing on the Eric's mat. And there's a kind of a specific way you count the errors. And again, for a while that was great, but then we got busier and we had another examiner, and there's some inter-examiner variability, and so it really wasn't that good anymore. And also I didn't have anything to show the parents, which is worth so much. So we were fortunate enough to get a VSR Sport. We looked at them. We looked at the different systems, and I think this is the most validated and the best system that's out there. So, we did pay a little bit more than what we could have for a couple other systems, but I've had absolutely no regrets since then. This is the kind of report we get. So when we have our kids do basically the BEST test, our 14 to 25-year-olds, they basically do a BEST test, but they do it computerized. And a couple of things that I found, number one is, again, the value of having this readout and be able to show the parents. When we had our first few kids get on this machine, I'll be honest, I thought, oh my gosh, that kid looked terrible, and look, he's all green, or, it doesn't seem right. But what I'm realizing is our BEST test probably wasn't very accurate, because these kids, as they get better, invariably their numbers get better, and their bars, the higher the bar, the worse the balance. And we see an athletic population, so even kids that are all in the green range, we get a gymnast that's on the green range, but they're up here. We know that that's not right. And we retest them, and we see that get better until we get down to that range where we really feel that kid should be in. So this has been absolutely huge for us. And what made it even better was being able to do the CTSIB tests. So And, of course, that's a clinical test for sensory integration and balance, which I like because it's simple and it makes sense to me. And I'm kind of glad I can't see the audience right now, because if there's vestibular therapists out there, they'd probably be chuckling at my description of it. You guys know a whole lot more about it than I do. But I think of the CTSIB as kind of looking at the three different systems that go into our ability to balance. Looking at that somatosensory system that kind of goes from the small nerves in our feet up our spinal cord, and the eyes and the vision system and the vestibular system. And, you know, when we're standing on the hard ground with our eyes open, all three of those systems are working. And then we stand on the hard ground with our eyes closed, and we take away that visual system. And then we stand on the mat with our eyes open, and we took away the somatosensory, and our vestibular and vision are working. And then we stand on that big, thick, foamy thing with our eyes closed, and the only thing that's really working fully is that vestibular system. So I like that test, and it's been really valuable to help us be able to test some of our younger and older kids. Vestibular and visual testing, right now we're doing manual testing. This is an area I honestly would like to improve. I think it's so important. So, you know, we do the we do a check of pupil size. We do a fundoscopic exam. We do VOR testing. We do Saccade testing. We do gaze stability testing. We do convergence. We do a couple cerebellar things. We do finger to nose and expand on that if need be. Dr. Balser, prior to, again, what I got back from was the sports concussion conference, but prior to that in February was the AAN meeting. And just prior to the AAN meeting, Dr. Balser put out a paper talking about the utility and the benefit of adding a simple visual test. They used the Candida test, which we used to do as part of our office. I think it's probably a better field test than an office test, but they added that to the SCAT-3 and to the BEST test, and found that it really increased their ability to diagnose concussion and to find those kids. So using the three tests together was much better than using any one of them or any two of them, and adding vision made a big difference. And when you consider that, you know, over 60% of our neurons are involved in the vision system, it makes sense that you should have some way of assessing that. So that was good. You know, the only problem with that study in my eyes was that the standard was computerized neurocognitive testing, and I'm not sure that was a good enough standard to compare these things to, but in any event, that came out, and I think is of significance. So Envision I don't have. We thought about it, and I would love to have it. It was a little bit too time intensive for our office, but boy, I would love to have it in a vestibular therapist or physical therapy office, or when we get our new center and can dedicate somebody to doing the Envision test. You know, when you're talking about trying to get kids back to sports, that's dynamic visual acuity. That's gaze stabilization. That's not static visual acuity. So the dynamic visual acuity test, you know, you're looking at, first you got to get a baseline visual acuity, and you got to get a baseline of how long, what's the rating period, or you know, how quickly can somebody recognize an object. So those two things are done first. And in dynamic visual acuity, the head moves at a certain rate, and you see how that compares to their static visual acuity. Gaze stabilization, then you're increasing that speed and really seeing how good they can do. And there's a regular level, and then there's kind of an elite level, where some of our athletes would have to go up to the higher level. And then you can repeat that after they've been trained and gone through vision or vestibular therapy. There's also a couple of advantages, I think, of having something like the Envision. Number one is that you can localize where the deficit is, because usually it's worse when you turn your head towards the ear where the deficit is. So you can kind of localize it. With the gaze stabilization test, you can find the speed of retinal slip. So, you know, and I think that probably means more to the vision and vestibular therapists that are there than it does to me, but that's going to be a valuable thing to be able to do as well. what do we do now for dynamic visual acuity? And we don't do it very often, quite honestly. I think when we use our Dynavision, I think we get some of that. But, we can move the head back and forth in front of a Snellen chart and see what their visual acuity is there. The problem is that, the tendency is to slow your head down. And we don't have any means. We don't have a red light coming up saying you're out of the zone and it's invalid. So this is a great tool. I'd love to have it. I'd love somebody right around us to have it. Right now we don't, but hopefully that'll change in the near future. This is just a picture of what that screen may look like. She's kind of close. I think the closest you can really be is 5 feet away to do that test. Dynavision. We do have a Dynavision. Again, something that our foundation was nice enough to get in the room. I love this test because we'll get to see the patient do it, see the athlete actually do the test. And not only have we collected data on, well, we do it by age group, but in our 15 to 17-year-old kids, we're approaching 400. So we got some pretty good data. We know where they should be. We know where they're out of range. Let me just show you the picture of the Dynavision in our office. That's it right there. That's one of the physician assistants who works in the office kind of doing the test. We kind of came up with our own concussion protocol. We do 4 different tests. You can kind of imagine from the screen that what happens is red lights come on. They come on one at a time for the tests that we do. And for the first test we do, which is called a proactive test, they come on and they don't go off until the athlete hits the dot. That goes on for 1 minute. We kind of consider that a reaction time test, and we record those numbers. Because our kids are competitive, sometimes when that light is just staying on there, they don't get as excited about it. So I kind of put a check and balance in there. So we do it with a 1 second wait, see the light will stay on for 1 second and then go off, and we see what percentage of lights the kid's able to get. Then we throw in some impulse control. We put some green lights in there, and we tell them not to hit the green lights, but hit the red, so it's counterintuitive. We have them yell out green when they see a green light. We have numbers popping up in here, so they're multitasking. They have to, verbalize the number, verbalize green when they say green, and hit the red. And then for the 4th section, we keep that exactly the same, except that we add some calculations in there. We make them do some simple math calculations with it. For our kids, when we do the baseline testing, because they're smaller and their arms are shorter, we took those last 2 rows out. But I think this is a whole lot better than flat screen testing. You can't slide your hand over it. You've got to be much more accurate. And I can tell you we've had a few kids that have flown past their testing. Their eye testing was okay. Their impact testing, both at rest and post-exertion, was normal. And even their balance testing was normal. And then we put them on this, and we found out that their gross motor testing was way off. And we have a couple of cases where kids got re-injured, and that was before we got this. And I kind of go back and wonder, would that have happened had we known what their gross motor numbers were. So another tool that I'm very happy to have. This is what their reports look like. We do get some nice reports to include in our charts, and you can definitely. It's used mainly, I think, as a training tool. I think the concussion management part of it is really gotten big. University of Cincinnati, Joe Clark's done a lot of work with it. Again, we're seeing a lot of patients. I love it. And our rehab people next to us have a machine that they're working with as a training tool too. I'm really excited. They just got a BSR Sport, and that's going to help us tremendously. So we'll still be able to work on balanced training with that as well, and then we'll do the kind of assessments in our office. One thing I always say, because we follow concussion and we test the balance of our athletes and our patients, and we test the gross motor skills, and we test how to do it neurocognitively. We check their visual and vestibular systems. But a lot of these kids, it's mainly emotional. So that's the other part where, you just got to remember to explore. What we should do, athletes, don't hide your symptoms. Tell your trainer or parents or coach. One of the things I've been most happy about over the past couple of years is the involvement of the athletes, where I'll actually have a kid come up to me and say, hey, Joe's not right. You better check him. Something's going on. So it does help to talk to those kids beforehand. coaches, it's getting better. We still have some who I don't think quite get it. Some of our coaches, some of our leagues now, all the coaches are going through USA Football and heads-up football programs, so that's great. But I encourage the kids to be honest about concussion symptoms. Don't make them afraid to be honest. It has nothing to do with being tough. The toughest person in the world still has a brain with the consistency of a soft boiled egg. So, that doesn't make sense to me. Parents, get your young athletes tested before their season. There is benefit in it. One of the things we started doing just very recently is when we do an impact test, we document the pupil size, convergence, and just a smooth pursuits, which I think is going to be very, very, very helpful. But what I would really like to do when we impact them is also get them on the VSR Sport and get that balance assessment, because that would be huge, and I hope we're going to add that as soon as next year. If they're injured, get them in to see somebody who has some experience in treating concussion. Educators, to return to learn is such a big thing. So having good communication with your teachers, with your school nurses is really vital. Got to somehow reduce that cognitive load early on. I'm starting to think that that's maybe more important than reducing the physical load. Physicians, ATCs, physical therapists, et cetera, keep up to date, educate, communicate with your schools and your coaches and your parents. No one of us is as good as all of us working together. Having that open communication is absolutely vital, in my opinion. And thank you very much. Again, I enjoyed a chance to talk to groups about concussion management. And that's it.
Dr. Masterson, thank you so much for that really thorough and informative presentation. This will conclude the recording of today's presentation.